This week's class, we are going to learn about atrial rhythms. Atrial rhythms occur when somewhere in the pathways of the atria take over to pace the heart. So when we were looking at our rhythms, we said sometimes for one reason or another, the sinus node can lose its pacemaking capability, and then the function has to be taken over by another site along that conduction system. Whatever has the fastest rate, that's what's going to pace the heart. So usually that is the sinus node. The sinus node normally has the fastest rate, but if it's not firing properly, or if there's irritation in the atrial pathways, it will take over. Now, atrial rhythms theoretically can be an escape mechanism just because the SA node failed, but about 95% of the time when you see an atrial rhythm where the atria rate has become faster than the sinus rate, it is usually due to irritability. Impulses originating from the atria are going to travel down the ventricles normally, so that means we should have a normal size QRS. Unless we had an underlying bundle branch block. So if I had a bundle branch block with my sinus rhythm and now I go into an atrial rhythm, I can still have that bundle branch block. But if I had a normal sinus rhythm to begin with, just because I changed to an atrial rhythm, I should still have a normal QRS. The only difference about this impulse, because it's originating from the atrial pathway, it's going to change our atrial depolarization. Our P wave tells us the atria have depolarized. If it is a nice normal sinus P wave, then I know it's come from the sinus node. But if my P wave is slower, it's rougher, it's notched, it's flattened, then I know it's probably coming from an atrial pathway. Since normal atrial depolarization is that P wave, abnormal atrial depolarization will have that atypical P wave, notched, flattened, or sawtooth. So atrial rhythms have several features in common. They originate from above the ventricles. They're supraventricular in origin. They have normal size QRSs. Unless there's an underlying bundle branch block, they will have an abnormal P wave. So the first one in this section that we will look at is premature atrial contractions, or a PAC. A premature atrial contraction is an irritable focus in the atrium that fires early and produces a single ectopic beat. What I mean by ectopic is abnormal. It's coming from an abnormal focus. It is a single beat, not a rhythm. So I have to still determine the underlying rhythm. That one beat, if I have a premature beat, it's premature, it's early. So that is going to make my rhythm irregular. But I have to look at what were they doing before they had that PAC. Were they in a sinus and then they had that premature beat? So I have to make sure I'm looking at underlying rhythm with this. When you document this and you say the person's having a PAC, you're just telling me what that one beat is. You aren't telling me what their rhythm is. The P wave for the PAC is going to be abnormal because it's not coming from the sinus node, it's coming from an atrial pathway. So it will look different than the other P waves. So in this example here, I have a rhythm that I can tell is irregular. And one thing I want to look at is my R to R speeding up and slowing down like in a sinus arrhythmia, or do I just have one beat that's making it irregular? So in this example, my QRS to QRS here, and then right here, it speeds up. This spacing here is a little bit faster. And then I have almost what looks like a time lag here. And then it goes from R to R being regular again. Now remember, if you had more than a 6-second strip, you would be able to see that regularity a little bit better. So I want to determine what's my underlying rhythm. Well, my underlying rhythm, except for this one beat, looks nice and regularly spaced. It looks like I have a sinus P wave for each and every QRS. My P wave looks like it's 1, 2, 3 boxes, so 0.12, it looks okay. And my QRS looks like it's a normal size. It looks like it's about 1.5 boxes, so 0.06. So it looks like I have a sinus rhythm. Now my rate here, 1, 2, 3, 4, 5, looks a little slow. So it would be a sinus bradycardia with this beat that came early. It's premature, it's early in the cycle. I have a P wave in front of it, but I notice my P wave goes upside down. It looks different than the rest of the P waves. My QRS, though, however, does not change at all. The other thing is, and this is going to be a distinction in the following weeks when we start looking at junctional rhythms. With PJCs, with things that come from the junction, we can have an inverted P wave, but we would have a short PR interval. With this one, I have an inverted P wave, but my PR interval is still 3 boxes here. So this would make it a PAC, a premature atrial contraction. So I would chart this sinus bradycardia at 50 with 1 PAC. In this example, I have a rhythm in this beat to this beat. Now this one here definitely comes in earlier. I can tell that the spacing is much closer, and then it goes back to a regular spacing, and then this one here came in close again. Now one thing you're going to notice with premature beats is when you have that early beat, it does make the rhythm irregular, but you notice this little time lag after it. This is not it's not like, oh my gosh, I have a sinus pause now. This is, I have this premature beat, and this premature beat is causing a little bit of time lag, because what happens is the SA node should have fired over here. It waits from here to fire again. So a lot of times with your premature beats, you'll have slight time lags after it, and that is just part of the premature beat. So in this one here, we said it's a regular rhythm. This beat here comes early. This here is regular. This beat comes early. My rate, 1, 2, 3, 4, 5, 6, 7, 8, 9. So it looks like I have a rate of 90. I have something else going on here, which we aren't ready to talk about quite yet, but I have a rate of 90. These here, I have a P wave for each and every QRS, and my P wave looks nice and symmetrical and rounded, so it looks like a sinus P wave. My PR interval looks like it's 1, 2, it's about 3 boxes, and my QRS looks like it's about a box and a half. So it looks like I am a sinus rhythm with, I have these beats that come early, they're premature. Now, do I have a P wave here? That's a good question. Normally, the P wave's a little bit more distinct to see, but look at what your T wave normally looks like, and then this here, it looks like I have something blended with it. So this beat came so early that the P and the T from the beat before it blended together. So I do have a P wave. It's just a little hard to be distinct about it because it's blended with that T wave. My QRS doesn't change in its configuration, and I have that time lag. That is a premature atrial contraction. Same here. This one came early. The P and the T have blended together. My QRS doesn't change. So I would have a sinus rhythm at 90 with 2 PACs. Now, some people would look at this and say, well, I think maybe this is a sinus arrhythmia. It's speeding up, it's slowing down. It's speeding up, it's slowing down. But in a sinus arrhythmia, you are going to have a sinus P wave across your entire strip that does not change. Even though the rhythm will be speeding up and slowing down, the P wave will not change in its configuration. In this one here, I have a regular rhythm. Then I have this beat that comes early, and then I go back into a regular rhythm. My rate is 1, 2, 3, 4, 5, 6, so a rate is 60. I have a sinus P wave for each and every QRS. My PR interval looks like it's okay. It's kind of hard to see the little boxes underneath it. My QRS looks like it's about 2 boxes, so about 0.08. So I have a sinus rhythm with this beat fires early. It has an inverted P wave, but I still have a normal size PR interval. The QRS does not really change in its configuration, so it would be a sinus rhythm at 60 with 1 PAC. In this example here, QRS to QRS to QRS to QRS is regular. This beat here came early, though. I can see my spacing from this beat to this beat, and then from this one to this one, this is much shorter. Then I have a slight little time lag, and then I go back to my regular spacing again. My rate is 1, 2, 3, 4, 5, 6, 7, 8. I still count this beat electrically in the rate, even though I want to look at what was my rhythm before this happened. So my underlying rhythm is regular. It has a P wave for each and every QRS. My PR interval looks like it's 1, 2, 3, little over 3 boxes, so about 0.14. QRS looks like it's a normal size, about a box and a half. And my QT interval looks like it's a normal measurement as well. Looks like maybe about 0.38 0.36. Then I have this beat that fires early. It's premature. My P wave is distinctly looks different. It's very spiked. It's very tented looking. I still have a normal PR interval measurement. My QRS doesn't change. So this would be sinus rhythm at 80 with 1 PAC. This example here, I can tell my interval measurements are very normal until I get to this beat here. It comes in early. And then I have a little time lag, and then it slows back down. My P waves look the same. They're nice and symmetrical across my strip until I get to this one that was premature. My P wave changed. It went half up, half down. So I have a different or an atypical looking P wave. My PR interval looks like it's 1, 2, 3, 4, about 0.16. And QRS doesn't change in its configuration. So this would be a premature atrial contraction. Now, especially when your rates are a little bit slower like this, or it's a little bit more spaced out like this, it almost looks like a sinus arrhythmia. Again, it looks like it's starting to speed up and then slow back down. But you'll notice here that these P waves are all the same except for this beat right here. The P wave has changed in its configuration. With a sinus arrhythmia, again, even though you're going to see the speeding up and slowing down, the P waves will not change throughout that entire strip. So this will be a sinus rhythm with the 1 PAC. This one here, my spacing, actually looks here like it is. You can tell the spacing here, it's sped up, slows down. Now it looks like it's speeding back up. So this one here, I have an irregular rhythm. So when I'm looking at this one, I have a sinus rhythm with a PAC. This one here is the speeding up, slowing down, but look at your P wave. Your sinus P wave does not change across that entire strip. Even though the rhythm is speeding up and slowing down, the P wave is in the same morphology for the entire strip. So this one would be a sinus rhythm with PAC. This one here is a sinus arrhythmia. Premature atrial contractions, what can cause them? It's very common in heart disease. It's also common with hyperthyroid disease. Pulmonary disease, your COPD patients, your emphysema patients, very common to see premature atrial contractions. Hypoxia, so not enough oxygen, and excessive caffeine intake. Significance really would depend on their frequency, but they do not usually require treatment. If they're really frequent, though, however, it may lead to a further dangerous atrial rhythm. They may go into an atrial tach or an atrial fib. So if we're seeing them a lot, it is definitely worth pointing it out to the physician so they can kind of keep an eye on it, check electrolytes, and they might even consider maybe possibly medicating them just so they don't go into a worse atrial rhythm. But PACs by themselves do not cause any real change in the cardiac output, so they don't generally need a major treatment. If they do decide to give a medication, medications that might be used are digoxin, beta blockers, calcium channel blockers, procainamide, amiodarone, all of those could be used. Now, the next one we're going to look at is atrial tachycardia. Atrial tachycardia is a rhythm where PAC, I told you a PAC is not a rhythm, it's just a description of an abnormal beat. When you have 3 or more of them in a row, 3 or more atrial beats in a row, then it's going to become its own rhythm. So atrial tachycardia is caused by an irritable focus within the atria, not just for that one beat, but for 3 or more. The P waves will have an atrial configuration. They may be flattened, they may be notched, they may be sawtooth. It is a regular rhythm. QRS to QRS to QRS is a regular rhythm. They're regularly spaced, and they will have a rate over 100, but usually atrial tachycardias are extremely fast. They are usually 160 to 250 beats per minute. They're frequently called SVT, supraventricular tachycardia, because what happens is the P wave of the beat merges or blends with the T wave of the preceding beat, and it makes the differentiation almost impossible to determine what you have. In this 3-second strip that I have here, I can see that my spacing from R to R to R is normal, In 3 seconds, I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So I would multiply by 20, so I have a rate of 200. Now, it's telling me that this little bump right here is my P wave. I really could not tell you that for sure. What I can tell you is I have a very fast rhythm. My P and my T look like they have probably blended together. How do I know something is supraventricular in origin? I know this because I have a normal size QRS. Supraventricular means above the ventricles. If something originated from above the ventricles, it came down the ventricular pathways normally. And if something comes down the ventricular pathways normally, you will have a normal size QRS. Normal size QRSs, so less than 0.12, they look narrow as they're going across the screen. So when I have a regular rhythm with a narrow size QRS and it is so fast, I am looking at it and I say I cannot tell if this is a P and a T blended together or if it's just my T wave and I don't have a P. I'm not really sure. I can call it a supraventricular tachycardia. Here is another example of it. QRS to QRS to QRS to QRS is normal. Again, this is just a 3-second strip. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So a rate of 200. I'm looking at this. I'm saying, okay, is this my P wave? And this is my QRS. And if that's so, where's my T wave? Or do I not have a P wave? This is my QRS and this is the T. Or is this the P and the T blended together? I do not know. So this generally, an atrial tachycardia, is usually going to be called supraventricular tachycardia because you're just not going to be sure where the origin of this rhythm is. But I do know it's a regular rhythm. I do know I have a normal QRS size, so I can call it supraventricular tachycardia at 200. Here, this is marked for 3 seconds, and this looks like the same one on our first strip, so we're going to skip this one, but let's look here. QRS to QRS to QRS to QRS to QRS to QRS looks normal. It's normally spaced. I can tell it's very fast. My rate, not all of this one fell in it. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So I've got 10 just in 3 seconds. So that's going to be a rate of 200. Now this one, it looks like I have a P wave here. My P wave looks a little bit more notched. One thing to remember is you can always compare to what they were doing before. If you have someone who's in a sinus rhythm and now they go into an atrial tachycardia, does that P wave look the same? If it was normal and rounded and now it looks a little more slanted, a little bit more jagged, I would call it an atrial P wave. The other thing to keep in mind, at a rate of 200, we said the sinus node maxes out at 160 to 180 beats per minute. So if I'm looking at a rate of 200, I know this isn't coming from the sinus node. I'm pretty sure this has to be an atrial origin. So I would call this atrial tachycardia at 200. I feel comfortable calling this one atrial tachycardia because I can actually see that P wave. It may be notched, it may be a little bit atypical, but I can actually see it. I'm not questioning if it's there or not. So whenever the patient has a fast rhythm, and it's hard to determine if you have a sinus P wave, an atrial P wave, and next week we'll be learning about things coming from our junction. If it's a junctional P wave, you can call it a supraventricular tachycardia because you know it's regular. We don't have clear discernible P waves, and we have a normal QRS size. So this example here, it looks nice and regular. My rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 200 again, because this is only 3 seconds. And again, I'm saying, okay, is this my P wave or is this my T wave? Is it a P on a T? When I can't tell, 90% of the time, atrial tachycardias are going to be called SVTs. Now the term paroxysmal atrial tachycardia or paroxysmal supraventricular tachycardia. Paroxysmal means you saw the sun start or the sun stop. It means there's a burst of it, not a long continuous rhythm of it. So with paroxysmal atrial tachycardia, you have that sudden burst of atrial tach. It starts suddenly or it stops suddenly. You catch the start or the stop of it. It is That's what you'll hear the term PAT for the paroxysmal atrial tach. Or again, if we're not sure if it's atrial or junctional or where exactly it's coming from, we'll call it PSVT, paroxysmal supraventricular tachycardia. And this is a good example of it. I'm basically looking at two different rhythms. It looks here like I have a very fast rhythm where it looks very regular. My rate in this 3 seconds is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. How seems to be our magic number today. And then it stops on its own and it goes back into a regular rhythm. My rate here looks like a rate of around 80. It looks like I have a sinus P wave for each and every QRS, and my PR interval on my QRS looks normal. So it looks like I was in an atrial tachycardia or an SVT that went back into its normal rhythm. So I could call it PSVT or PAT if I thought it was atrial. Here is what supraventricular tachycardia looks like on a 12-lead ECG. And you'll notice again, here's lead 2 that we normally monitor in, or V1, which is equivalent to our MCL. But you can see in all of these leads, it looks very fast, but the QRS looks normal as it's going across. And you're looking at it and you're saying, okay, do I have P waves? In my lead 2, I'm not sure I think that's my T wave, so I don't think I have a P, not really sure. Here, maybe I have a P with a T. Because I can't tell for sure, SVT is kind of a good catch-all terminology when you're just not sure. This is showing you a SVT in lead 2 on the top and MCL on the bottom. So again, you can see that it's a regular rhythm. My rate is very fast. Now, if I'm thinking this is my P wave, and maybe I just have a flattened T wave, or I'm thinking I might have a P on the T because it looks like this. I've got this nice little spike right here. So I'm thinking I have a spiked P wave on top of my T. So I'd be tempted to call it an atrial tach, but in all honesty, the safer bet is just to call it an SVT. It's a regular rhythm. It is a normal QRS size, and it's so fast we're just not 100% sure. So atrial tachycardia and SVT, what causes it? Exercise. Now, if that's not a good reason not to exercise, I don't know what is. Hypertension, coronary artery disease, respiratory failure, thyroid disease, aminophylline for our asthmatics. Many times, supraventricular tachycardias are caused by a re-entry mechanism, an abnormal rhythm circuit that allows a wave of depolarization to repeatedly travel in a circle in cardiac tissue. So if the re-entry circuit involves the AV node, it may be referred to as an AV nodal re-entry tachycardia. It's still usually just referred to as an SVT. But one thing to keep in mind is this is a regular rhythm because it is one irritable focus causing it. I don't have multiple areas of the atria doing it. This is one irritated area in the atria that's causing all of the problems. Our significance, well, we have a really fast heart rate, and some of these, the heart rate is, we've been counting 200. So we're talking about heart rates between 160 to 250 beats per minute. We have a very shortened diastolic phase, and our ventricles fill during diastole. So that is going to decrease our stroke volume. Now, granted, our heart rate is very fast, but you still, when you look at stroke volume times heart rate, that heart rate is not going to be able to maintain that cardiac output for any length of time. Plus, our coronary blood flow itself, our coronary arteries, we said, fill during the diastolic phase. So we are going to have less blood flow coming and less oxygen coming to the heart muscle itself. And it's using its oxygen up faster than it should be because the rate is so fast. So this kind of gets itself into a very perpetuating problem here. And you will see a patient become symptomatic with these very quickly. So if we have a patient who's symptomatic with atrial tach or SVT, one of the things we can do is a vagal maneuver. Now, physicians can do carotid massage, but nurses are not allowed to. So carotid massage, you might see the physician do. A Valsalva maneuver, that is something we can do. So if our patient's in a really fast heart rhythm, we can ask them to bear down. We can ask them to cough forcefully. We can have them blow on an occluded straw. Trendelenburg position. If their blood pressure is dropping and you put them in Trendelenburg, that will increase, that actually will stimulate the vagus nerve as well and can actually cause the heart rate to slow down and the blood pressure to be supported. Cold pressor treatment works extremely well with children and young adults, not so much for your older adults. And what cold pressor treatment is they take a bag of ice and put even a little bit of water in it to make it really cold, and they just put the bag on the face and they go, ugh, and it causes a diving reflex, and it's been shown to slow that heart rate down. I've actually seen one doctor just take some ice water and throw it in the patient's face. It actually worked. Medications that can be used if the vagal maneuvers aren't working. Adenosine is usually our drug of choice. So adenosine, our common dose is 6 milligrams, and we push it very, very fast. It is a rapid push as fast as you can, followed by a normal saline flush. It can be repeated one time with 12 milligrams. Now, if it works, it's very dramatic. You might actually see a pause and the patient's eyes roll back in their head and they have this look of horror on their face. And you're like, oh my God, I just killed my patient. But again, the half-life is only 5 to 10 seconds. It goes right away. And then hopefully it broke that cycle they were in and the sinus node can take back over. Another drug that is frequently used is cardizem or diltiazem, which is a calcium channel blocker, usually 10 to 20 milligrams IV over 2 minutes. Now, those are the two more common drugs you're going to see for this, and which one you're going to use is going to depend on what department you're working in. So, for instance, if you work in an emergency room, they give adenosine a lot for this because you have the ER physician there. If you're working on a telemetry floor, adenosine, you generally need to have the physician either in the room with you or at least present in the unit, depending on where you're working. Where cardizem or diltiazem, you do not. So if you're working on a telemetry floor, chances are you're going to be giving cardizem for this. If you're working in an ER, you're probably going to be giving adenosine. Verapamil is another choice. Verapamil is also a calcium channel blocker, but I have to be honest, once cardizem came out, we very rarely give verapamil anymore, just because there isn't as much, with cardizem, you end up having less hypotension than you do with verapamil usually. Beta blockers are another good choice that can be done, and they're all dosed a little different depending on which one is used, and then procainamide can be used for this as well. Now, if our patient is so unstable that we don't even feel we have time to give medications, we feel our patient is so unstable that their blood pressure is dropping, their level of consciousness is dropping, we think they're going to be coding on us shortly, we can do electrical therapy and we can cardioverse our patient, do a synchronized shock. When we cardiovert, we always have to have an IV in place, and hopefully we can medicate them, pre-medicate them if possible. So we're going to shock them, and we're going to usually use 50 to 100 joules of current. And so what we do is we will put our electrodes on the chest, and we hook it up to our crash cart or to our defibrillator on our crash cart, but we always make sure we sync it. We'll use the sync button. What the difference between defibrillation versus cardioversion? Defibrillation, you're taking a preset amount of energy and you're shocking that person. As soon as you charge up and press that button, it delivers that large dose of energy. It can fire anywhere in the cardiac cycle. The difference between defibrillation and cardioversion is a synchronized defibrillation is basically what it is. We are going to sync the machine of our we're going to sync the defibrillator. We're going to hook the electrodes from our defibrillator to our patient, sync the machine so the machine is reading the person's underlying heart rhythm. And now when we shock them and we press that shock button, it's not going to deliver that shock until it picks up the next QRS complex. Now, if they're firing at a rate of 200, believe me, that's not going to take long. But what this does is it has them be shocked on the QRS complex instead of that downslope of the T wave. Remember, our downslope of our T wave is our vulnerable period. And If you have a strong enough impulse or something firing during that phase, you can actually cause electrical chaos. You could actually make this worse. So we want it to fire on the QRS complex, and there's no way by eyesight you could do that yourself, so we rely on the machine to be able to sync to it. You have to remember with defibrillation or with cardioversion, when we shock that person, defibrillation isn't jump starting a heart. Defibrillation is doing a massive depolarization of the heart all at one time, hoping that we can stop any chaotic rhythm that they're in, and the SA node will kick back in and take back over. The other thing that can be done for this rhythm is overdrive pacing. And overdrive pacing is if the person has a permanent pacemaker or a transvenous pacemaker. You really cannot do overdrive pacing with an external pacemaker. But what overdrive pacing is you turn the pacemaker on and you turn it faster than what the patient's own rhythm is. So if the person's in an SVT at 200, I am going to turn my transvenous pacemaker up to 250. Whatever's fastest is what's going to pace. So now the pacemaker takes over. And hopefully what that does is it gives the irritated area in the atria time to relax, time to just break that cycle it got itself into. And I don't leave them at a rate of 250 with the pacemaker for extended period of time. As soon as it's had a chance to break that cycle, now I'm going to start turning the rate down, hoping that I can just turn it off within a minute or so, and the SA node has just taken back over. So we are going to stop and take a little pause right there.